Can you hear me?
We can, Chris. Thank you. And welcome back, everyone. The joy of technology. So I will give each of us just one more minute to get reconnected, and we'll get started again.
Rochelle, this is Nina. Can you hear me?
I can. Thanks,
okay.
Nina.
Good.
All right. Welcome back, everyone, and thank you for clicking that link again to rejoin us. Excited to be sharing our webinar series, and sorry for the technology issues. Again, my name is Rochelle Bartnick. I'm with the American Heart Association in St. Louis. I cover the St. Louis area as well as outstate Missouri. And my collaborative partners today that put this series on are Chris Kummerfeld with the Missouri Department of Health and Senior Services and Marianne Kimball with the Health Quality Innovation Network. So thank you for joining us. And Chris, I'll turn it over to you for a quick opening comments.
Yeah, thank you very much, Rochelle. I think it's very important to highlight hypertension education, since about 9.7% of all deaths had high blood pressure listed as either a primary or a contributing cause in Missouri in 2020. And as a basis of comparison, worldwide, 12.8% of all deaths had showed that high blood pressure was either a primary or a contributing cause of death. Just a few other statistics that really underscore the reason that hypertension education is really of utmost importance in Missouri. Hypertension deaths went from 468 in 2019 to 577 in 2020. And heart disease deaths went from 14,959 in 2019 to 15,932 in 2020. So this increase may be related to Missourians who delayed or avoided seeking non-COVID related medical care at their local hospital or doctor's office due to the pandemic. But the point is that we need to continue this effort to continue hypertension education. So thank you very much for participating today. With that, I'll turn it over to you, Rochelle.
Wonderful. Just a couple highlights on how you can control your screen. And if I could get a head nod if my slides are advancing for you, perfect. So you have control over what you see. It's there on the screen. You might need to just adjust view or toggle to bring the slides a little bit larger. We do invite you to join us in the comments section. Just be sure to include all panelists and attendees so we can all see your comments. And then we will have a Q&A section at the end, towards the end of the webinar. We invite you to use the Q&A button for that, so that if we have a chance to type our answers in, everyone would be able to see the answer to those questions, and we will read as many as we can get to. Well, today's topic is team-based care and the role of the pharmacists play in hypertension control. And I'm excited to introduce to you Dr. Annie Eisenbeis. We were able to send out the speaker's bio in advance yesterday afternoon, so hopefully you got a chance to read that. But Annie joins us as a practicing pharmacist at a family-owned pharmacy in rural central Missouri, and she's the director of practice development at the Missouri Pharmacy Association. Strategizing, preparing, implementing successful programs to enhance quality of care and improved access for all patients is really the focus of her work. So Dr. Eisenbeis, I'm so excited that you're here today, sharing your expertise. And with that, I will turn it over to you.
Perfect. Thank you so much. All right, I'm going to share my screen here. All right, and then hide this so I can see. Okay. Thank you guys again so much for joining us today. This is definitely a topic near and dear to my heart as a pharmacist and working for the Missouri Pharmacy Association. I'm really excited to be here, especially in kind of the promotion of why pharmacists should be part of your care team and patient care team. So thank you again for joining. Without further ado, I'll dive right in. All right, so I wanted to kind of start just with this overview of chronic disease progression, and I used hypertension, but really it can not be limited just to hypertension, that most chronic diseases progress in this way with those risk factors and lifestyle changes that need to be made, but that are a lot harder to make than they sound, leading to pre-hypertension, then the actual diagnosis of hypertension, and then potentially leading to complications with comorbidities and then across transitions of care. So in my opinion, there are actually 3 key elements in slowing this disease progression for any chronic disease, including but not limited to hypertension. And those 3 elements include the first one being patient buy-in. So including not just motivation to make changes, but also that ability and access to be able to implement those changes. I think the second would be education. This is probably a huge component of slowing any disease progression. And when I say education, I don't just mean that the patient, family, and caregivers have all of the information that they need, but that also they understand it. And then the third being follow-up on a routine and regular basis. And I'm going to kind of come back to those 3 key elements, that patient buy-in, education, and follow-up, to really enforce why a pharmacist should be on your care team if they're not already. And so pharmacists are probably one of the most accessible yet underutilized healthcare professionals. There's pharmacists involved in every facet of healthcare and across transitions of care. Several pharmacists in hospitals, whether it's inpatient or outpatient, to community pharmacies, to clinics, to long-term care facilities, and all of the other facets as well. You can also see a pharmacist without an appointment in almost every area of the state and country. So they can provide access to a healthcare professional in areas where there are healthcare deserts, and sometimes are that only healthcare professional around for miles. According to the National Association of Chain Drug Stores Foundation, about 9 in 10 Americans live within 5 miles of a community pharmacy, and I don't think that can be said for any other healthcare professional. I also want to reiterate as well, or kind of enforce, that pharmacists don't replace a current team member. So when I say add a pharmacist to your care team, I don't mean that we are replacing anyone else. We're just a piece that we need to add to that puzzle. It's important to me that, we understand that we're all in the same boat, trying to do more with less and stretch our teams and ourselves to the limits. And this has been even more exaggerated with the COVID-19 pandemic. So pharmacists are not only a resource to offload some of those care touch points for patients, but they can, for patient follow-up and monitoring, but we can also assist in services that are not currently being provided at all due to staffing or time restraints in other areas of healthcare. So I'm going to go back to those key elements of slowing disease progression. So we have that patient buy-in. Pharmacists are also one of the most trusted professions in America, with nurses up there at the top. Go nurses, by the way. We can easily build rapport and get to know our patients because we see them often. For example, our pharmacy has a drive-through, the one that I work at in rural central Missouri. And I was kind of thinking about how well I get to know my patients. And I'm really thinking how many other healthcare professionals on this webinar know their patients' pets' names when they come through, and if they see their patients' pets in addition. So we have patients that bring their dogs through the drive-through with them on a regular basis. So I actually really get to know not only my patients, but all of their caregivers and service team members, including their dogs. I also think education and counseling are just a common task that pharmacists perform on a regular minute-to-minute basis. Questions arise not only related to prescribed medications, but also in the over-the-counter aisles or on the phone. Again, you don't have to make an appointment to see a pharmacist. You can just walk on in with no copay or charge. And I also actually, when I put this or added this component in there, I remember hearing recently from another healthcare professional that pharmacists are not trained to talk and counsel with patients. But I just want to reiterate, this is actually a primary focus of the PharmD programs because pharmacists are advocating nationally for provider status to be able to bill for cognitive services, including education and counseling patients. And so patient counseling is an integral part of our schooling and services that we already offer. So this is one component of school that is throughout the entire curriculum for PharmD programs. And how I mentioned follow-up and routine monitoring as that third huge component to slowing disease progression. We're there at the time of diagnosis when the patient is picking up that first prescription for an antihypertensive medication or other chronic disease medication. And then we're there when they come back every month or don't for it as well. So I noted here that when we're extending care with community pharmacies, so on average, pharmacists see their complex patients about 35 times a year. And when you think about that, that number sounds really high, especially compared to primary care physicians who they may see 2 to 4 times per year. But it really makes sense, especially now that I have a little girl, you know, going to the pharmacy and getting an antibiotic more often than not, going for something over the counter or just kind of those chronic medications that you're getting monthly. And then many pharmacies as well, including those pharmacies that are in the network mentioned earlier, that I oversee, the Community Pharmacy Enhanced Services Network, kind of a mouthful, but we call it CPSN for short. These pharmacies also have medication synchronization programs. So it's a little bit different than autofill. I don't really like to think of it as autofill. It's more that we follow up with our patients on care calls every month. So every month our patients that are on our MedSync programs, we check in with them. We make sure, you know, what medications are they needing that month before we fill them. And then this is actually the perfect opportunity for flagging non-adherence or questions or concerns about medications if there might be potential for non-adherence. So if a patient says they're not needing a medication that's due this month, that's definitely a flag for the pharmacist or myself or whoever to go in and talk to that patient and really address those concerns. It's also actually an area where we are trying to implement addressing social determinants of health as well. So kind of how this slide mentions that we see our patients so often that I even know who their dogs' names are. It allows us to really be able to dive into their life at home and have those conversations around addressing those social determinants of health. So for example, one project that we're involved in here at the Pharmacy Association is creating a dual role training program for pharmacy technicians wanting to become community health workers. And so we've developed a training virtually for them around implementing this in the pharmacy space and addressing those social determinants of health. So pharmacies are kind of already a healthcare hub. So all of the specialties and different providers are all sending something to a pharmacy. So we're seeing pretty much that med list from all of the providers. But now we also get to be that resource hub as well for our patients and our community. I also wanted to bring up, kind of going back to that pharmacy school curriculum, there was in about 2014, a pharmacist patient care process was actually defined by all of the pharmacy stakeholders nationally that came together and really outlined what this process looked like. And it's been taken up by all of the schools across the nation. So I wanted to kind of go through this process briefly before diving into where pharmacists can improve blood pressure control when they're added to that care team. So the collection process includes collecting current medication lists, med use history, and this includes not just med use for prescriptions, but also over the counter and herbal products. We also collect relevant health data that's related to medical history, wellness information, test results, and physical assessment findings. And then I think a component that pharmacists are really great at is also looking at those lifestyle habits, because we're really in that community setting as well to be able to see those lifestyle habits. I know when my doctor asks me kind of based or how much caffeine I've had in the last month or how my eating habits are, it's a little white lie sometimes. I try to be as accurate as possible, but maybe I'm just lying to myself sometimes about it as well. And so we can really see those preferences for lifestyle change opportunities, and then looking at those socioeconomic factors and those social determinants of health, like I mentioned before. We also have that assessment. So that includes assessing medications for appropriateness, effectiveness, safety, and patient adherence. And then also looking at potential risk factors and health and functional status, health literacy, so related to not only knowing all of the information related to a medication or chronic disease, but also understanding it. And then pharmacies have been really big in the immunization space, as evident with COVID vaccinations, but also other vaccinations and addressing preventative care, because that's a great opportunity to talk to patients not only about vaccines, but also other preventative measures that they can take. And then we establish a care plan. So this plan will include addressing medication-related problems and optimizing medication therapy, especially being that hub of healthcare information and data for other providers sending it to the pharmacy. It kind of all gets that into one space. And so we can really look at the overall patient medication therapy list and then optimize that for the patient. We also help them set goals for therapy and achieving clinical outcomes. This is actually probably primarily in the self-monitoring space. So pharmacists are pretty involved in this space, especially with hypertension, SMBP, and then DSME for diabetes and pre-diabetes in the DPP space. And I'll kind of touch on those a little bit more later on in the program. We also support that care continuity, so including that follow-up and transitions of care, and then implementation. So implementing the plan is where I think pharmacists play a key role, as well as that last step of follow-up. So addressing that medication problems and engaging in preventive strategies. We can provide education and self-management training and referrals as well. And then the follow-up with continuous monitoring and evaluation of medication appropriateness, safety, and adherence. Because if you're not taking the medication, it's really not going to do its job. And then clinical endpoints that contribute to the patient's overall health, outcomes of care, including progress towards or achievement of those goals of therapy. So pharmacists are really involved in all of the patient care process mentioned here. And then I think, again, the biggest role that we play is in that follow-up with continuous monitoring and evaluation, because we're not just there at the clinic or just at the inpatient setting in the hospital. We are following them across that continuity of care into the community and into long-term care facilities if needed, et cetera. So I wanted to bring up that Community Preventive Services Task Force recommendation related to adding a pharmacist or team-based care. So they do also mention adding nurses to the team as well to improve blood pressure control. They mention the importance of managing medications as a team. And I think this also relates to medication optimization. So not just managing medications, but optimizing the regimen for what's best for that patient. Providing health behavior counseling, coaching, or education to support blood pressure management, adherence, and lifestyle activities. Pharmacists can add to all of these elements to lead to greater blood pressure control. And then a quote from the recommendation was that when pharmacists were added to teams, median improvements in blood pressure control and systolic BP were greater than the overall median effect estimates for these outcomes. And I wanted to highlight that because really it's not just applicable to hypertension and blood pressure control. Pharmacists can be involved in a lot of other chronic disease management spaces and helping with medication management and optimization, because let's face it, most chronic diseases have medications related to that treatment plan. Hopefully we can catch patients in that pre-stage, whether it's pre-hypertension or pre-diabetes, and get them back to just having potential risk factors. But once we hit that stage of needing medications, I really think it's vital to add a pharmacist to that care team. I also wanted to mention that pharmacists can also support, sorry, I'm going to go back a slide. I went a little ahead of myself. Pharmacists can also support cholesterol management. So not just related to hypertension, but also adding in that cholesterol element with optimizing medications. We can actually perform point of care testing, addressing those barriers to care, and then education on the importance of cholesterol adherence and taking that medication as prescribed with patients. I found that this was a key medication therapy management intervention that would pop up often. So MTM is an opportunity for pharmacists to provide a service that's reimbursed by the patient's pharmacy benefits on their insurance. And this was something that would come up where we would talk to the patient and educate them on cholesterol medication adherence. Unfortunately, MTM, although it's great to be able to provide a reimbursable service so that pharmacies across the nation implement it right away, it's pretty retroactive versus proactive. So this approach looks at a patient who's already non-adherent. They have missed kind of their due date of their medication for at least 3 months, sometimes at least 6 months. So they're already non-adherent, and addressing those concerns or questions that led them to be non-adherent or potentially social determinants of health, leading them to be non-adherent, are not addressed until it's a little late down the line. So there are other proactive services. Now, unfortunately, these have some barriers for pharmacists. And these barriers I address on this slide. So why we can't just jump right in. So federally, pharmacists are not recognized as providers and can't bill under our own individual NPIs. This doesn't mean that we can't get our own NPIs. So in Missouri, for example, pharmacists can bill as providers under Missouri Health Net or Medicaid, and we have to have an individual NPI to do that. So for example, being able to bill as a provider under Medicaid, we can also bill for services. So not just the prescription itself, but things like independently being able to write prescriptions for NRTs and help with smoking cessation. These are things that are covered by Medicaid, and then opening access to that support counseling. So whether it is in smoking cessation or self-management programs, like I mentioned before, DSME, DPP for diabetes and pre-diabetes, and then SMBP. And with SMBP too, I actually wanted to bring that up as well, because we are looking at a program now that we're implementing in a couple innovative pharmacies in community sites to move SMBP into a more continuous follow-up opportunities, such kind of pulling it into remote patient monitoring. So we're utilizing blood pressure monitors and a platform that these kind of provide real-time numbers to, that the pharmacist, providers, and the patient all have access to. And we're training pharmacies in our enhanced service network with an education platform in order to provide these remote patient monitoring services. So we're starting with blood pressure, but there are other opportunities for pharmacists in diabetes and other diseases that they can be involved in remote patient monitoring. And it really, to me, makes sense, especially when you tie it in with we're already seeing the patient 35 additional times a year. So I think that ties well with why pharmacists need to be added to that team, especially when you're looking at that self-management or monitoring at home and having that support structure for the patient. We also actually can bill for these services. So under remote patient monitoring, we can bill for some services like that, or chronic care management and others under a physician or other providers NPI. This doesn't need a collaborative practice agreement. So that's a really common misconception, even in the pharmacy world, that in order to bill for these services, you have to have this lengthy protocol with a physician and somehow convince them that you should be able to provide these services. I think a barrier to this is not only that it's misunderstood that you really just need that billing service agreement in order to define what you're billing, and then that profit sharing afterwards, because these are typically services that are added to a already existing clinic, and that they're not being provided already. But one barrier to this that we've found, as well as actually referrals or kind of bidirectional referrals across multiple care settings, is that large health systems don't always allow their physicians to partner with any professionals outside of the health system. So we found that this leaves out key care team members that could significantly impact positive patient outcomes, such as pharmacists. Another is that clinic staff are maybe not willing or understand how to work with or include pharmacists on their care team. I mentioned before that we actually are trying to educate and train pharmacists to provide that remote patient monitoring, for example. There are pharmacies doing this across the country, and they've kind of shared all of these templates and tools for how they got their foot in the door with the clinic staff, and how happy the clinic staff are that they have a pharmacist on their team now. So we have all of that data and information, and it's just kind of disseminating that not only to the pharmacies to be able to share, but also to other providers and healthcare professionals. I also wanted to note that shared EHR access does make this easier for everyone, but many times clinics, and it's not necessarily the people that work in the clinic or the providers, it's kind of that corporate potential bureaucracy in there that they aren't willing to grant EHR access. And I completely understand sometimes with this related to privacy policies and just kind of not opening yourself up to potential liability. But not granting EHR access does make collaboration a lot more burdensome because you have a much more manual process for potential collaboration. So overcoming these barriers and why we need collaborators. So not only adding a pharmacist to your team, but why pharmacists need you. We do want to provide the services such as remote patient monitoring, chronic care management. We can help with annual wellness visits and behavioral health integration and interventions. And we can bill for these services. We just have to utilize somebody's NPI who we are collaborating with to be able to bill under a service shared agreement and kind of that profit sharing model. So these are what we like to call profit only shared models. So if the pharmacist isn't making a profit for the clinic, then the clinic doesn't always pay the pharmacist for that service or intervention. We haven't found that to be an issue in the past because usually it's adding something that wasn't there to begin with. So there's typically profit sharing available. And then we've also looked at overcoming some of these barriers by just using other pharmacists to collaborate with. So like I mentioned, pharmacists are in that kind of continuum of care space, and we're in multiple healthcare settings. So we are looking at opportunities for collaboration between pharmacists in a community setting and clinic-based setting, and sharing information and interventions and how they can best help their mutual or shared patients. I also actually, sorry, jumped ahead again. In overcoming these barriers, I also wanted to bring back up that shared EHR access. I think this also provides a need for a robust health information exchange. So I wanted to bring that up too, because there are potential areas for HIEs to be included. And I just think if we had a really robust HIE, this would be a great opportunity for collaboration and providing better team-based care for all chronic diseases, specifically hypertension. And then pharmacists providing care throughout that disease progression. So kind of going back, I've mentioned all of these before, but I just kind of wanted to hit home with this slide in that medication optimization and self-monitoring education, and then that pharmacists are across that coordination of care. So like I said, we're trying to tie in clinic-based pharmacists and community-based pharmacists to collaborate and better serve their patients and collect better outcomes for patients. We also found too that in that space, shared EHR access in other pharmacist to pharmacist collaboration projects in other states also showed that there were a lot of missed communication potentially between the EHR and the pharmacy software. So the fact that we're using all of these different softwares meant that there was potential for miscommunication. So things that got discontinued potentially in the EHR and changed to another medication. The pharmacy now has 2 scripts because the original one didn't get discontinued, and the patient is on potentially having adverse reactions to having 2 duplicate therapies. I also think that it's important to note, oh, my slides went away. Okay, sorry. I think it's important to note that we have the community-based pharmacy and that they can support that community-based primary care. So diving into addressing or meeting patients where they are and addressing the needs that they have within those communities, I think pharmacies just really extend that care of primary care. And I consider them, again, provide or care extenders of PCPs. So kind of my thought process with this is that just like we have primary care physicians, I think we should have primary care pharmacists, and that we should have those PCPs and PC farms working very closely together. I'm going to wrap up with my last two slides, just kind of stating if it's all about quality care, then you need to add a pharmacist to your team. And even if it's all about the bottom line, you still need to add a pharmacist to your team, whether that's related to hypertension control, cholesterol management, medication optimization, or any other disease, chronic disease management. We are here to help. And without further ado, I have a question slide here. And then I'm going to stop sharing my screen so that I can also see those questions coming in.
Thank you, Annie. So we'll move to the Q&A portion now. So if anybody would like to ask a question, go ahead and either enter it into the chat or the Q&A. And Annie, there's a couple of questions for you. Yes. Can you list some of the reimbursement services? You might have answered that one.
Yeah, so there's kind of depending on the level of service agreements, there's reimbursable services, and it also actually depends on your state. So because pharmacists don't have provider status federally, there's some services that we can't bill for to Medicare, for example, but then different states allow within your scope of practice to bill either Medicaid or commercial plans or kind of those employer-based insurance companies. So reimbursable services to Medicare, for example, Part D include medication therapy management. Again, that's somewhat retroactive. It's telling you that a patient's not adherent after they've already missed some of those doses. And then there's pharmacists can actually bill for diabetes education, so DPP and DSME. It gets a little confusing because we're actually billing under the pharmacy's NPI and not the pharmacist's NPI for those services. So actually that causes a lot of potential barriers for reimbursement issues in that we get sent to the pharmacy benefits when really we're trying to bill for medical benefits. It's just under the pharmacy's NPI, not the pharmacist's individual NPI. Again, in Missouri, we actually have provider status under Mo Health Net. So if you do enroll as a provider with Missouri Medicaid, there's additional services that you can bill for. And it has a much more robust medication therapy management program as well through Cyber Access or Direct Care Pro. And then there's other services that if you're collaborating with a physician, you can bill for things like remote patient monitoring for various disease states, chronic care management, again, various disease states, annual wellness visits, behavioral health, and some other kind of service or education and counseling based programs. Those also do not require a collaborative practice agreement that adds another element of potential billing opportunities. Barriers, again, actually related to not having provider status with federally with Medicare, actually also are related with that commercial insurance plan. So some of the states that have provider status have actually gone through legislation to say pharmacists need to be added to all insurance plans. So not just their Medicaid program, but also commercial insurance plans as well. And that's opened the door for additional collaboration as well. I see the other questions. I guess, Marianne, do you want to ask them or do you want me to jump in?
Either way.
Okay. I'm a fast talker.
You want to address one about billing under the AP, RN or PA?
Yeah, I don't believe most of our services we can bill under an APRN or a PA. It's similar to where we would need that either collaborative practice or clinical service agreement with a physician. And I know Medicare does allow for like non-physician providers, but I don't think pharmacists are included in that. And then I don't think we can bill under a non-physician provider's NPI, unfortunately. That's actually probably an area for additional advocacy on our end as well. So yeah, I think it does have to be a physician for most of these services, unfortunately. Not unfortunately, I guess, but I wish we could collaborate with more than just physicians.
And can you talk a little bit more about the collaborative practice? And I believe that's probably the collaborative practice agreement, perhaps?
Yes. So that collaborative practice agreement in Missouri, for example, each state may have some different requirements for pharmacist training in relation to collaborative practice agreements. But for Missouri pharmacists, you would require a collaborative practice agreement if you were going to make any changes or initiate or discontinue therapy. That collaborative practice agreement includes pretty much everything related to that process involving the pharmacist with that collaborative provider. So it would include, when you initiate therapy, under what circumstances, for what patient population, or eligible patient criteria. And then it also includes all of the follow-up requirements as well. So how you communicate with that physician, and even like within how many hours or days do you communicate what elements. It's a lot more extensive. But I mean, which makes sense because then both providers understand what process they're going through for initiating, discontinuing, modifying any sort of therapy. Now, for those services that I mentioned earlier, that chronic care management, remote patient monitoring, annual wellness visits, most of those actually do not require any sort of changes to be made to the patient's therapy regimen. Instead, the pharmacist would be making recommendations to the provider, and then they would initiate, modify, or change the therapy. And so that's why it doesn't actually require that collaborative practice agreement, that extensive document that goes through the entire process of how they're going to collaborate. It really is just more related to what services the pharmacist provides, who bills for that service under that physician's NPI, and then when they get paid, how that profit is potentially shared. So that's what that is related to.
Okay, and then there was a question, are these roles currently being filled by other healthcare professionals, RNs, case managers, or is there a gap in this care?
Great question. So I think several of these roles or potential areas for interventions or services provided by pharmacists may be filled in other capacities by other healthcare professionals as well. And again, I'm not advocating for pharmacists to take those roles or manage those roles differently. I think that the gaps in care is not that this care maybe isn't being provided, it's the access to care. So because you have pharmacists within 5 miles of almost every American here, we can reach potentially more patients. So we are extenders of this care.
And then there was a question, what about outcome, medication therapy management, or Optum? Would that be one?
So those are platforms that allow pharmacists to bill for medication therapy management. And that's what I'm referring to when I mentioned that MTM is really retroactive and not a proactive approach to medication or kind of therapy management in general. So outcomes or Optum, when they pop up with the MTM interventions, it's because the patient is already non-adherent, or they've already been diagnosed with diabetes for several years and are not adding a statin therapy, for example. And so pharmacists can bill for MTM services through these, but usually it's very hard to be proactive in this approach.
And then the next comment is also, are you including retail pharmacists? My experience as a resident in a suburban St. Louis community, they are overwhelmed with volume and do not have time to educate, monitor, evaluate, and discuss healthy lifestyle, etc.
Great point. So yes, I'm actually including retail pharmacists, but I guess I'm a little bit specialized when I look at my retail pharmacists. So we have, and when I say community pharmacists, that's what I mean, is those retail pharmacists that are in the community setting. So my network of pharmacies, it's about 130 pharmacies across the state. that are those community pharmacies performing enhanced services. They actually are typically your independent or small chain pharmacies because they look at that and want to provide additional services for the small communities that they serve. Now in the St. Louis area, we actually have several of these pharmacies as well doing these enhanced services. And typically they are our high performers because they have more access to other providers to collaborate with than potentially your healthcare desert pharmacies. Now, I totally understand sometimes often when we think of the pharmacist at potentially the big box chains, they are really overworked and understaffed and overwhelmed. And just like with other healthcare professions, pharmacists are experiencing kind of this national conversation about burnout. And I know other professionals in healthcare, every healthcare space are experiencing these same discussions and conversations because we're all in the same boat that was exaggerated with the pandemic as well. So we're adding on additional services and nothing really got taken away. But I will say that the pharmacists involved in these enhanced services are really, really dedicated to providing these services and almost not necessarily offloading dispensing, but that kind of traditional role of the dispensing pharmacist. They may be kind of making just a little bit less priority, I guess. So for their patients, rather than just putting them on an autofill program, they're putting them on that medication synchronization, following up every month, providing diabetes education for those patients, et cetera. So yes, there are definitely pharmacists that are overwhelmed, and whether it's volume, and I typically think of the big box chains. So I'm also somebody that likes to shop local. So I also do the same with my pharmacies. And those are the ones who I probably would reach out to first if I was wanting to collaborate in some way. But I probably want to also say that the rural pharmacies as well are very aware that they're, especially if they're in a healthcare desert or for their patients who have limited access, they're very aware of kind of being that hub of information and healthcare in general. So our rural pharmacies too are just super high achievers and high performers and really wanting to be active in this space. I also don't want to kind of diss or make it sound like the big box chain pharmacists are not doing amazing things. Just like with local shops, big corporations sometimes make decisions that aren't always best for the patient or for the provider. So the pharmacists in those big box chains are excellent usually, and they again are just overwhelmed, potentially burnt out. And it's not because they're not wanting to participate in additional services for patients. It's more that they're limited by potentially corporate policies.
Okay, and the next question is, when talking to the pharmacist, what would be the best way to approach them? And it says, I am new to this, so.
Great question. I guess it depends on what space you're in. So if you are with kind of a clinic or either a health system or a small hospital, for example, or an FQHC, honestly, that's kind of what my job is, to help you facilitate these relationships and build potential programs. So I also oversee several different grant opportunities involving pharmacists and pharmacy teams. And I am happy to kind of test the waters, so to speak, with building these relationships. Because when I mention those barriers, there aren't really necessarily cookie cutter solutions either. So I am happy to help pharmacists find ways to collaborate with other healthcare professionals. And if it's the healthcare professional who isn't a pharmacist coming to me and saying, how can we facilitate these relationships? That's even better.
Okay. And there's another comment. It says, yes, also the pharmacists in Miami, Florida, they are overwhelmingly busy with minimal staff working in the pharmacy, such as CVS and Walgreens.
Yes, not to call out any of the big box chains, because again, those pharmacists themselves are amazing individuals. They went into this to be healthcare providers. And then it's kind of that, just like in other areas of healthcare, the metrics and numbers seem to just kind of get lost, or patient care gets lost in those metrics and numbers. So things just get piled on them and they lose integral staff members. So anyway, yes, I could go on and on about that. But yes, pharmacists are really interested in providing this care. I think just sometimes it gets lost in the potential metrics with big box corporations.
And then we have people asking if there will be a recording of the presentation, and there will, and that will be sent out to everyone. And we have a lot of people asking for Annie's contact information so they could do some follow-up.
Yes. Am I welcome to put that in the chat? I am happy to have 1,000 emails by tomorrow morning that I have to respond to about pharmacist team-based care and collaboration.
Okay.
So it's super easy. I'm going to put it in the chat, but it's also just Annie, ANNIE at MORX.com. I'm glad my last name isn't in there because it would be a little bit more difficult.
Hey, Annie, I've got a couple of questions. Is there any particular problems with respect to medication adherence with any certain types of hypertensives? In 20, as you know, in 2017, the hypertension guidelines changed and they became more rigid. So in a theoretical sense, you know, providers might have pushed out medications out earlier to patients. So with that being said, there might have been resistance on the part of patients with respect to medication. So
that is a great question. So I'm hesitant to say that there's kind of one class of medication
there's
or
a lot
even
of
one type, but honestly, kind of off the top of my head, for example, statin medications, even though those aren't specifically hypertensives, tying in that cholesterol management with hypertension management, statins are actually probably one that are harder to manage adherence potentially because with patients who are taking statins, you know, they're not necessarily feeling any poor symptoms or feeling sick in any way. That kind of silent killer, so to speak, of adding that statin in to help is hard to address with patients because they just don't feel like they need it potentially. And so you're adding that as a preventive measure, and nobody enjoys remembering to take a medication. So I think without that potential not feeling great, so for example, you know, with hypertension, for some patients, if they stop taking that medication, they might experience a headache, et cetera. So at least then they're experiencing that symptom to remind them to take that medication. Whereas with the cholesterol medications, especially statins, they either don't have those symptoms to remind them or they don't feel the need because they feel just fine. I think also with all medications, it's actually just looking at that bigger picture for the patient. So sometimes it's not even just that the doctor either pushed it out earlier. It may just be that they don't understand or have all of the information for kind of addressing why they're taking the medication. So I'm somebody too that always likes to know why I'm doing whatever it is I'm doing. And so I think adding that why factor into the education. Allison Smith also commented the single pill combinations. Yes, if you can combine less medications into one so that you're only taking one for the same thing, I definitely think that's an option, or extended release is always better. My husband, for example, had to take a medication recently, and he said, he told the doctor, if I have to take it twice a day, I'm going to forget the second time. I'm only going to remember if it's in the morning with my other medications. And so I think, and he has a pharmacist for a wife. So I think even then, you know, kind of understanding like this is burdensome to have to do this more than once a day, and setting those reminders more than once potentially.
Thank you.
And I think that was our last question in the chat. If anybody else had anything that they wanted to enter, feel free to go ahead and enter it. And if we didn't get to your question during today's session, we will email you out the responses. And Rochelle, I'll turn it back over to you.
Wonderful. Yes, thank you. And thank you, Dr. Eisenbeis. I mean, every time I've listened to a presentation of yours, I get a new idea and a new way of thinking about things. So thank you so much for sharing your time and your talents today. I just want to remind everyone that this is a series, and so we'll have 2 more workshops like this. Our next one is on COVID-19 and hypertension. So really excited about that one. Same way to register, same time, same location, hopefully not the technical issues. And so, you know, I just want to extend my thanks on behalf of the American Heart Association. You know, we are dedicated to extending the healthy lives of the healthy years of a person's life, and chronic disease management, the control of hypertension certainly is integral piece of that. And as an organization, we have an association-wide goal to work in communities, to work with providers, to empower individuals on how they can control hypertension. And you'll be hearing more about that in our 3rd workshop. So with that, I want to thank you today for being here. Chris, Mary Ann, do you have any closing thoughts?
Just thank you, everyone, for joining today. Go ahead, Chris.
Thank you very much. I look forward to your participation in the next workshop.
Yes.
Very good. And so as we close today, I do have a video I would love to share, created as part of our National Hypertension Control Initiative called Get Down the Pressure. So as we are thinking about hypertension education and engaging our community, I'd love to just show this resource for you as we close today. So after this video, the webinar will end. And again, thank you so much for joining. Let me make sure I'm sharing my sound. There we go. Start it over.
Get it, slip it, cuff it, check it. Talk to doctor now and share it. Get it, slip it, cuff it, check it. Talk to doctor now and share it. Gonna get it, gonna slip it, gonna cuff it. Check it, talk to doctor and share it. Gonna get it, gonna slip it, gonna cuff it. Check it, talk to doctor and share it.
Get it, slip it, cuff it, check it. High blood pressure silently affects millions of Americans. Staying on top of your blood pressure is as simple as these 4 easy steps. Self-monitoring is power. Visit manageyourbp.org to learn more.
All right, thank you again. And that concludes our program for today. Have a wonderful rest of your week.
Bye, everybody.